Hello and welcome to another episode of Ultrasound Tips and Tricks. This month we're going to be talking about small bowel obstruction diagnosed on bedside ultrasound. So it should come as no surprise to any of us that small bowel obstruction is a very common cause of abdominal pain in all comers, especially elderly patients. This is a table from EP Monthly showing the most common causes of abdominal pain in emergency department patients. The reason I bring this up is because small bowel obstruction can be diagnosed very quickly and accurately using bedside ultrasound. And my goal here today is to show you some easy ways to do this and to speed your diagnostic approach. So this is a chart showing the relative sensitivities and specificities of obtaining abdominal films in CAT scans and ultrasounds in the diagnosis of small bowel obstruction. I don't think any of us are performing plain films anymore for this, as we are really routinely going to CT scan. But I want to show that the ultrasound scans is a highly sensitive and specific way of finding a small bowel obstruction and can be done in less than just a couple minutes at the bedside. So getting right into it, we're going to use a diagnostic approach called the lawnmower technique, which is to use the curvilinear abdominal probe over the abdomen, essentially going up and down or side to side across the abdomen in a lawnmower type fashion. This will ensure that you capture all the quadrants of the abdomen without missing any, which will increase your diagnostic yield. And this is really what we see on abdominal ultrasound. Usually the bowel is really not visualized on abdominal ultrasound. It's a nuisance. It gets in the way because there's so much gas in it. When you've got somebody with a small bowel obstruction, you actually see fluid-filled loops of bowel. And that's actually very apparent on somebody with an obstruction. And so the first thing you notice is that there is a visible bowel and the bowel loops are distended. The cutoff point, which is typically used, is 2.5 centimeters dilated. And as you'll see in a couple of these pictures, it helps when they stack on top of each other in a fashion just like this. And so this is a video of what we call back and forth, which is essentially back and forth sloshing of peristalsis because there is an obstruction. And so finding this and seeing the intestinal contents going back and forth is actually highly specific for small bowel obstruction. And so the three criteria we really look at is dilation over 2.5 centimeters, the to and fro sign, and lastly the thickness of the bowel wall, which I didn't mention before, but really a bowel wall thickness over 3 millimeters is highly abnormal. Usually it's a gestalt look when you're doing this exam to see how dilated they are, but using these measurements can help significantly increase your specificity. So that's pretty much it. Obviously the pitfalls of doing abdominal ultrasound for small bowel obstruction is you can't differentiate between an ileus, you can't find a transition point, a lot of these things that are required. So this is not used for definitive diagnosis. It's really meant to be used to sort somebody out. You know, when you get to see some older person and you get in there with the abdominal ultrasound probe and you're looking maybe for AAA or maybe a gallbladder, and then really what becomes most apparent is that they've got these fluid-filled bowel loops, as you say to yourself, okay, well, these other things are highly unlikely, and it seems most likely based on sensitivity and specificity of this test that it's a small bowel obstruction. And you move forward with routine testing, lactate, CBC, and abdominal imaging with CT. But again, maybe able to speed you up and help get your ducks in a row for the admission process for that patient. That's it for this time. If you guys have any questions, as always, reach out, and I'll be happy to share thoughts on this with you. And otherwise, we'll do another session in a couple months. Thanks.